Hello, everyone. On behalf of the Spina Bifida Association staff, welcome to the Spina Bifida Association's Ask the Expert session, Adult Health and Aging Well with Spina Bifida. My name is Judy Thibodeau, a member of SBA staff, and I and my colleague, Jessica Palmieri, will be with you for tonight's question and answer session. Tonight, our panelists will provide their responses to the questions asked during the community information session last month, as well as to the questions you have submitted when registering for tonight's session. If there is time tonight, the panelists will respond to questions that you submit using the Q&A feature found at the bottom of your screen. Before we begin, a few housekeeping notes. If you have a question or comment, please feel free to use the Q&A feature at any time, and we will try to get to as many questions as possible. You may also use the chat function, which we will not be monitoring as closely. You will receive the recording of this presentation and an evaluation survey. Please take a minute to complete the survey so that we will learn what topics are important to you for sessions like this in the future. Lastly, today's event is being recorded and we will post the video to our website soon. Our panelists for tonight's session are Ms. Sarah Struwe, SBA's President and CEO, Dr. Tim Bry and Dr. Brad DiCiano, SBA's medical directors. Welcome to Sarah, Tim, and Brad. Sarah.
Greetings, everyone. We're so glad you could join us. Thank you for our kickoff to our education series this year. And it's appropriate that this is the topic and the questions that we'll be answering. So as we go through the evening, I just want to encourage you to ask questions and leave comments. We'll do as much as we possibly can. And we are paying attention to what you're telling us. So hopefully we'll be able to answer your questions. Take care.
All right, so I'm Brad DiCiano. I am a physical medicine and rehabilitation doctor. I'm also the director of the Adult Spina Bifida Clinic at UPMC and the associate medical director for the Spina Bifida Association. So I'm going to be fielding a lot of these questions that came from our presentation last month, especially the ones that are more geared towards folks who are aging. And then Tim is certainly going to chime in as well with some recommendations as appropriate. And I first wanted to say thank you for all of these really thoughtful questions. We have a really nice selection of questions from a lot of different topics. So I wanted to thank everyone for putting so much thought into them. And I wanted to first just start with a disclaimer that we certainly can't answer individual questions that are consultations for a personal medical problem, but we'll try to answer some general questions related to those questions that might be a benefit to everybody. And along the way, I'm also going to try to give some recommendations about different types of providers that can help you with these problems, because I think some of the issues that do come up are because people just can't find the right type of provider in the adult care world. So we'll just jump right in. The first topic is bone health. And the first question is about different types of treatments for osteoporosis. And the person asking this question was concerned about having some GI issues, including constipation. And because some treatments like this medication Reclast can cause some GI side effects, the person is concerned about taking that medication for treating osteoporosis, and they wanted to know, do we have any suggestions? And I would first start by answering this question by saying that, the treatment of any condition, including osteoporosis, is about balancing risks and benefits. So anytime you take a medication, you have to think about the potential side effects and whether those are not as concerning as the potential side effects of not taking the medication. So If treating the condition is more important than reducing those side effects, then certainly it's recommended that we treat these types of conditions. So in this case, I think that people should just be aware of the types of side effects that can occur from medications like osteoporosis treatments. So because they can cause diarrhea or constipation, if that's something that you struggle with, just realize that if you are on those types of medications because you need it for treating osteoporosis, then you may just need to be more vigilant with a bowel program, and you may need more help with that. So that is something that your spina bifida clinic or a PM&R physician or a GI physician could potentially help you manage. So it's good to plan ahead when you're taking a medication to anticipate what those side effects might be and have a plan for how you might treat them in the setting of spina bifida. The next question is about what might we do for someone who's having issues with their toes. So this person's toes are described as bending and tightening, and what could be done about that. One thing I would say is that certainly there are different treatments for orthopedic issues of the foot. A lot of times this involves orthotics, or it might involve orthopedic surgery. But one thing I would point out here is that sometimes when the foot is becoming really tight and the toes are changing, it could be a sign of something neurologic happening. So sometimes this can happen in the setting of something like tethered cord, which is related to spina bifida. So I would say that first, it would be important to determine whether there's something neurologic going on, which would involve consulting a neurosurgeon. And then if it's not thought to be related to that, then an orthopedic doctor, a physical medicine and rehab, or PM&R doctor like myself, or even a podiatrist would be a good provider to see for this type of problem. The next question is about rods that were put in someone's back for scoliosis. This happens a lot as a treatment for severe scoliosis, and this person's concerned about where the rods attach to the areas of the spine. And it's important to realize there's different types of surgical procedures that are done for scoliosis. The hardware can be put in different parts of the back, but it is true that there are situations where there can be problems with where the hardware attaches to different parts of the bones. And if there are worried that it is becoming loose, if you're noticing that the scoliosis is worsening, or you're having more pain, or you're noticing, changes over the skin that might indicate that the hardware is coming close to the surface, those would be indications to see, an orthopedic surgeon because of this issue. The next question is about preventing osteoporosis for people who use wheelchairs. And so I won't be able to go into detail in this. We did cover this topic in our presentation, so I would refer you back to look at the presentation from last month. There is a whole section on osteoporosis. The other thing I will point out is there is a brand new healthcare guideline on bone health and osteoporosis that SBA has published, and it's on our website. So that is something that you should check out and you should share with your providers. I think in short, it's really important to think about certain things in preventing osteoporosis, and that includes calcium, vitamin D, weight bearing where it's possible, including exercise, and also screening for osteoporosis. So that might include doing bone density testing. And there's a lot of caveats and different decisions that we make when deciding, who to screen and who to treat. And so this is really a personal type issue that is dependent on the person and their age and their certain situation. So the osteoporosis and bone health guidelines go into great detail about how to handle that situation. And that's actually why they were written, is because there actually isn't a lot of research in this area, but there is some clinical consensus on what we can do to help ameliorate that. And likewise, the next question talks about recommendations for bone density screening. Again, the guidelines go into more detail about who should be screened and when. So I'd refer you back to the guidelines for that. One thing that I will point out here is that we have to think a little bit carefully in terms of the bone density testing that is done. Oftentimes we look at different anatomic areas. When we're doing that testing, we might look at the wrist or the low back or the hip. Those are common places that the bone density testing is done. And when the physician orders the bone density testing, those are sites that they automatically do. But those are also sites, especially the low back and the hip, that might be abnormal in somebody with spina bifida. And so sometimes, especially in folks with spinal cord injury, we look at other areas of the body, like the long bone in the leg, the femur, for example. And so it's really, one thing I would recommend is to talk to your physician who's ordering that bone density testing to see, if the standard anatomic locations would be appropriate, or if they should order the test in a different way. And there are some facilities that actually don't have the capabilities of testing certain areas of the body. So that's something to just keep in mind. All right, I think we can move on to the next slide. The next section is on urinary tract infections and bladder health. And I really like this first question because I think it brings up some confusion about what is a urinary tract infection technically. This person is asking about whether somebody doesn't have symptoms of a UTI, but what if they do actually have a UTI? And so I want to clarify a few things here. So first, the definition of a urinary tract infection includes symptoms. So you don't really have a urinary tract infection if you don't have symptoms. And let me explain that a little bit more. So many people have bacteria that live in their bladder, especially people who catheterize. And so when we test the urine of anyone who catheterizes, generally we always see bacteria in that urine, but that doesn't mean that it's an infection. It just means that the bacteria are living in the bladder. They're not invading the tissue or taking over or multiplying. When the bacteria do that, when they get a little out of control, they multiply, they take over, they cause inflammation in the tissue. They cause symptoms of a urinary tract infection. So people can develop pain, they can develop burning. Sometimes that's difficult to detect because people might not have sensation. So people might have other symptoms like fever. They might just generally not feel well. They could get headaches. So generally, when we're looking to treat these type of situations, we're looking to treat the person. We're looking to treat the symptoms with an antibiotic. And we don't treat when there's just only bacteria in the bladder. There's also, ways to try to prevent urinary tract infections. And we do go over that in the presentation. So there's a whole section on prevention of both urinary tract infections and also prevention of sepsis. Sepsis is when a urinary tract infection advances to the point that it spreads throughout the body and causes more serious effects. The second bullet is about taking an antibiotic to prevent urinary tract infections. And this person had good success with this over their life. And one thing I will just recommend is that this is something you really need to talk to your urologist about. You taking antibiotics regularly every day for your whole life is not something that we do as much anymore because there hasn't been great research to show that that has been effective. There are other ways that we prevent urinary tract infections. However, there are some people who have been on this type of treatment for a very long time, and sometimes if it's been effective, some urologists are hesitant to change that, if it's worked for you and hasn't caused problems. The downside of taking antibiotics for a long period of time is that you can become resistant You can grow bacteria in your bladder that is resistant to that antibiotic. And that's what some research has found, is that when people are on these medications for long periods of time, when they do get infections, then that antibiotic won't really work for that infection. And certainly antibiotics, as all medications do, can have side effects. So sometimes when you take things, you can develop problems from taking those drugs for a long period of time. So this is really something, to speak with your urologist about.
Brad, can I make a comment here?
Sure.
So I'm Tim Bry, obviously, as you know, but I'm an adult with spina bifida who is now 67, soon to turn 68. And I will state that I have had a bladder augmentation for a number of years. So that changes potentially my management versus people who have not had a bladder augmentation. I used macrodentin for a long time at the suppressive dose of 100 milligrams. And while I found that useful, in my particular situation, my urologist and my primary care physician had concerns. One of the potential side effects of macrodentin, although it is considered a rare side effect, is that individuals who take it for a long time can develop respiratory symptoms, a particular condition called a respiratory fibrosis, which makes breathing difficult and which makes getting oxygen into your lungs and exhaling carbon dioxide out of your lungs potentially challenging. I don't think we know how frequent that is. So it may be worth a discussion. My urologist and an infectious disease doctor over the last couple of years changed my dosing from 100 milligrams a day to 50 milligrams a day, and then 50 milligrams every other day from a suppressive standpoint. And my urologist currently feels that in my case, with a bladder augmentation and the fact that my augmentation makes mucus, or what the gut colon makes, feels that the literature is most supportive of doing bladder irrigations with a saline solution. And I will say over the last 4 months since I have had my new urologist, I've been doing the bladder irrigations at least once a day, sometimes every other day. And I've not had a urinary tract infection. My urine does not look as clear as it did on the macrodentin, but I've also not had the other symptoms that I personally experienced. And I would be, so this again is based on my personal opinion and not anything professionally. I seldom ever developed fever with a urinary tract infection in my entire life. I would experience pain. I would experience other kinds of symptoms. And because I catheterize 4 to 5 times a day, I actually catheterize into a container so I can visually inspect my urine and compare what's happening over time. That's not the way we necessarily teach it, but at 67, soon to be 68, that's the way I developed over many years of my life. And so I would be fever and pain. Pain, I think, is very common. Fever is not as common in my personal experience as just the feeling of unwellness and fatigue and pain. And by the time I ran a fever, my urinary tract infection was generally more severe. So I think it's important for individuals to be aware of what their symptoms are, and to be really in discussion with their urologists, primary care physicians, physiatrists, whomever you see, about what the options are to be off of antibiotics. I now am at a stage of 67, 68, having lived through this life, where most of my urinary tract infections, when I have true infections, are very difficult to treat outside of a hospital. And so I'm glad to be off the macrodatin, and I'm glad this seems to be working for me. But there are pros and cons to both sides. And again, I would just be really cautious about discussing all of those with a urologist. Sorry for the long discussion.
You brought up a lot of really great points, Tim, and it relates actually to the next bullet, which this person thinks that they're asking whether always a urinalysis is needed before prescribing an antibiotic for a UTI, especially in the setting where somebody knows what their symptoms are when they have a UTI and they know that pattern. I think you bring up a good point where a lot of people know the types of symptoms they get when they have a UTI. But what's really important here is that, even sometimes when you think your symptoms are related to a UTI, it can be something else. You can develop pain and fever from other types of infections, for example. So sometimes, the problem can be coming from somewhere else. And so it is really important to test the urine before prescribing an antibiotic. And generally, we send off the urinalysis. We may also send off a culture. The urinalysis just shows some very basic things about what's in the urine. It might show whether there's bacteria, but it might show also some other signs that it could be an infection, like white blood cells. That's something that we see that indicates that the body is reacting to the bacteria, not the fact that they're just living there. And then with the culture, we send the culture off, and that tells us if the bacteria grow, and if they grow, what antibiotics will kill them. So it's really important then to have that test available so that we know whether the antibiotics we're using are going to be effective. And like Tim said, we can develop resistance. And so if you take an antibiotic and it doesn't work, we need to know, whether it's because that antibiotic is the bacteria is going to be resistant to that antibiotic. So that's why we do recommend that the urine be tested before somebody starts taking an antibiotic. You don't want to take the antibiotic and then have the test either, because that antibiotic might kill off the bacteria that's in the urine. And then when you send it off for testing, you won't find the bacteria. So it is always a good general rule of thumb to send that off. Another caveat here is that some doctors will go ahead and will send the urine off for testing and go ahead and prescribe an antibiotic before we know what antibiotic will work. And that's important if the person is developing symptoms, you want to prevent it from getting worse. But in that case, we might have to change the antibiotic depending on what the culture tells us. So if the culture comes back and says, no, that's the wrong antibiotic, then we'll have information about which one to switch it to. So a lot of things to think about when developing these kinds of symptoms.
I will also add that, again, as an adult with spina bifida, having been a pediatrician, but now living my life at 67, I think having a culture and not automatically treating is critically important. We know that antibiotic resistance is happening. I have grown out several bacteria which are multi-drug resistant. And so I think the best use of antibiotics is to really get a culture. And if possible, wait until the urinalysis and the culture come back positive before absolutely treating. Again, if you've had more serious symptoms, the physician may wish to cover you with some antibiotic trying to prevent you from getting sicker. But I think everything is dependent on the culture, and we want to use the best antibiotic without the most side effects, but also not covering things that we don't need to cover to reduce antibiotic resistance.
Right. The next bullet actually is also about urinary incontinence, but it relates to research behind using PTNS, which is also called percutaneous tibial nerve stimulation. So this is a way that we can stimulate the nerves in people to try to treat bladder incontinence. And this person is asking about the research behind that and potentially negative consequences.
So I will try to address that question. So urinary frequency, urgency issues are actually fairly common with women in general. The literature I could read looked at 10 to 20% or thereabouts. And there has been reasonably good evidence in typically developing women who just have some sense of bladder issues. I cannot find any evidence that indicates that this has been used, trialed, or used in people with spina bifida. And the people that I asked, who are urologists, including adult urologists, have said that people who have spinal cord changes are much less likely to benefit, and that they've often seen no benefit. Even in people, even in women who do not have spina bifida of some form, it is considered a third-line treatment where other things should be tried first. Now, if you who asked this question has true spina bifida occulta, and that by that I mean the classic definition of spina bifida occulta, where the back side of the bone does not fuse appropriately, but the spinal cord itself is normal, then it definitely, I think, is worth talking to your urologist about this. None of the studies that I could find, including the randomized controlled trials, specified women who had spina bifida occulta versus women who did not have spina bifida occulta. So they classified them as women who are, quote, normal. But if you have any evidence of spinal cord abnormality in addition to occulta, then the likelihood that this is going to work is appears to be significantly less. Again, there's no real research in spina bifida, the more classic sign, spina bifida occulta being a subvariant, has not been studied as well. But again, I think some of the women who were potentially included in the randomized controlled trials probably had spina bifida occulta, but nobody asked them and nobody looked at x-rays to see if that was the case. So I think this is worth discussing with your urologist and what other treatments might be appropriate for you.
The next questions are about bowel management. This next bullet is about bowel issues that go along with aging and what a person might be able to expect. What I will say is there's a couple of things to keep in mind here. One is that people tend to become more constipated later in life, and so the bowel program can be a little bit more complex if you need more interventions. The bowel program can also be more difficult to carry out if you have mobility issues or pain issues. And so actually doing your bowel program can be a problem. And then finally, if you have mobility issues because of aging, it might be harder to get to the restroom on time. Just getting there might be a problem. And so oftentimes we need to think about how to preserve and improve mobility along with, are there changes that we need to make in somebody's bowel program? So I think all of those things kind of go hand in hand, and it's not just about the medications you take, it's about, how to manage the whole program. The next question is about how people with spina bifida do with having a colostomy. And what I will say is that there's obviously lots of different ways to manage the bowels. The colostomy is a surgical solution. Sometimes people use that solution after they've tried other solutions. Sometimes colostomies are placed when somebody has significant skin issues. And where I've seen the colostomy used the most is folks who have had pretty bad pressure sores that require surgery, and the skin needs to be protected for a long period of time. And so sometimes the surgeon will recommend a colostomy while the person is having their skin treatment. And sometimes those can be reversed. They can be taken out, and the colon can be reconnected after that skin surgery is done. And we find that some people choose to keep them. They find that the colostomy is convenient. Some people like them. Some people don't like colostomies. They don't like managing the bag. They may have problems managing the bag. It may be difficult for them. So I really do think it's a personal choice, and it's something to talk about and compare to other options that you might have. And then finally, this person is asking about an ileal conduit. This is actually a bladder surgery. An ileal conduit is a way that the bladder is reconstructed as a way to preserve. Part of the reason that is done is to preserve kidney function. If the bladder itself is too small or has too much pressure, and the bladder is usually reconstructed with other tissue, like from the bowel. This person is asking whether they read somewhere that ileal conduits cause a person to end up on dialysis, and I don't know of any evidence for that. In fact, I would say that an ileal conduit is actually generally done to try to preserve kidney function. But we have to be careful here about things causing other issues versus being associated with other issues. It might be if there are people who are on dialysis and they have ileal conduits, it's not necessarily that the ileal conduit caused the kidney problems. It may be that they were at high risk for having kidney problems to begin with, and that's why they got the ileal conduit. So they may have some renal problems down the road. So it might be two things that are associated here in what you're reading, but not necessarily that the ileal conduit caused it. Okay, I think we can move on to the next slide.
Brad, I will also say that we try now in current care to avoid ileal conduits in favor of other interventions. But if you have an ileal conduit, obviously follow up with your urologist is very important. But that was one of the treatment options in my younger years that we had available when we didn't have other things available.
So this next question is probably the one that a lot of people have on their minds. And how are we sure that we're going to the right doctors to treat us? And I think it's difficult because there aren't a lot of adult providers out there who understand how to treat spina bifida. And also adults can have so many different problems that sometimes, the right providers is really a team of people. There's also different types of providers that can provide some of the same kinds of treatments. For example, some urologists will treat bowel problems, and so will PM&R physicians like myself will treat bowel problems. So it may be difficult to know who to go to sometimes. But what I would say is it's really important to have a primary care doctor to start. It's really important to have a spina bifida clinic if there is one in your area. And where people lack spina bifida clinics, one solution is going to a PM&R physician like myself. So physical medicine and rehabilitation Sometimes we're called physiatrists. Sometimes we're called rehabilitation doctors. We can provide a lot of care that a lot of adults need. So we can treat some bowel and bladder issues, skin issues. We can handle equipment and bracing. We can handle musculoskeletal problems. So there's a lot of options there. And oftentimes we have the connections to the different surgical providers that you might need. So we're generally linked to neurosurgeons, orthopedic surgeons, urologists, who are familiar with people who have neurologic conditions, because rehab doctors treat people who have spinal cord injuries. So if you can find a provider who treats spinal cord injury, that may be a good solution for you. And finding the right provider for the right issue can be tough. We realize that, and that's part of the reason why we have the National Resource Center. So if you have trouble finding a provider, you can reach out to us and we can help you locate one in your area. The next bullet was asking about states being asked about providing medical care. And I'm not sure I understand the question. I hope I understand it. I think they might be referring to something that I presented in the presentation a month ago. I talked about a study that we did in the state of Pennsylvania, where we asked primary care providers if they were familiar with the Spina Bifida guidelines. And surprisingly, a lot of primary care providers in our state either didn't know what the guidelines were or didn't follow them. And it pointed out the fact that a lot of primary care providers needed to be educated about the guidelines and the importance of using them. So that particular study was just done in the state of Pennsylvania. So I hope that answers that question. I'm not sure if I interpreted that one correctly. The next question is about coverage for durable medical equipment. And what's being done about that. And this person complains that the process can take months and has lots of errors. And I agree with you. I think this is an area where we can make a lot of changes, but it takes a lot of advocacy. And I can give you some examples of what's being done and things that you can do to participate in the process. So there's a lot of research going on in assistive technology, like, for example, in the area of wheelchair technology. We do a lot of research with wheelchair technology at my location at the University of Pittsburgh. There's lots of other universities that do this type of research. And the research has a couple of purposes. One is to develop new technologies that are better. So technologies that are lighter, that are more ergonomic, that fit you better. But also studying how those technologies are used and how people get them, the problems with people getting them on time, the problems with the process. And based on the research, we can come out with better technologies. We can also come out with recommendations for how to change practice and policy. And I'll give you an example of something that happened recently. There's been research that has been recently done on these components of power wheelchairs called seat elevators. So that's the seat of a power wheelchair that raises and lowers a person. And many people who use power wheelchairs find seat elevators to be very enabling. They help you transfer more easily. They help you reach objects to do your daily activities. And it's something that Medicare never covered in the past. But due to more research that's been done recently that has shown that seat elevators are effective, combined with the advocacy that many organizations, including the Spina Bifida Association, has done, got Medicare to decide to cover seat elevators. So that's a way that research and advocacy combined together can really change some of these processes and policies that people find really frustrating. So something that you can do is to participate in research and also participate in advocacy and realize that also, all of these things require funding. But when people work together, they can be quite effective. All right, we'll go to the next slide. The next questions are about mental health. one question is about spina bifida and mental health with aging, and I'll combine that sort of with the other bullet, which asks about people with spina bifida being at higher risk of early onset dementia or cognitive decline. And so what I'll say here is that I'll qualify this by saying there aren't a lot of research studies that contain adults who are in their very late years. So certainly there are research studies that look at adults and different age groups, but fewer and fewer studies look at people in their seventh decade, eighth decade, ninth decade. And we know that currently the preponderance of people who are in those age groups are people without shunts, who were never shunted. So we don't have a lot of research really to answer this question. But what we do know is that as people do get older, especially people who have hydrocephalus, or especially people who have had multiple shunts over their life, the problems with memory can be accelerated. So you can see memory problems arising earlier in people with hydrocephalus or people with multiple shunts than in people who don't have those issues. And so that's how I will kind of answer that question. I don't know, Tim, if you have any insights on that one.
I don't have any other insights on that one. I would say that the first question related to mental health is really complex because mental health is dependent on physical health. It's dependent on relationships. It's dependent on living situations. It's dependent on connections. I don't know of any research that is longitudinal, meaning happening in the same group of individuals over years, that looks at this issue. We understand that many adults with spina bifida have mental health concerns. Many of those, I believe, are a combination of factors and not one single factor. At least that's the case in my own situation. And so mental health is really important, but it's important that we look at potentially all aspects of our entire environment that may contribute to mental health. I will also say, since I have just retired from active clinical practice, though I continue to serve as SBA's medical director, that I have found that changing from a situation where you are working or where your life is fairly stable to now a sudden change is potentially a mental health risk, not just for people with spina bifida, but for all people. And it's important that you think about those aspects as you get older.
And as far as providers here, so this is where a neuropsychologist can be very helpful. So talk to your providers, your primary care doctor, or your spina bifida clinic, or your PM&R physician. They can generally link you with a neuropsychologist who can help counsel you on what to look for as you're aging. The next question came up actually during the presentation when I was talking about Chiari malformations. And so I want to take a step back here and just explain the difference between a Chiari 1 and a Chiari 2 malformation in case people don't understand that, and then address the question, which is what can cause Chiari malformations. So a Chiari malformation means that your part of your brain sits very low in your skull, and part of the brain can actually be in the spinal canal instead of within the skull itself. A Chiari 1 is something that we see in the general population in people without spina bifida typically. And Chiari 1s can cause headaches, they can cause balance problems, and they affect just generally a small part of the back part of the brain called the cerebellum. A Chiari 2 is generally seen in people with myelomeningocele. So most people with Chiari 2s have myelomeningocele, and most people with myelomeningocele have Chiari-2s. And this is where a few extra parts of the brain are affected. It can also affect the balance part of the brain, but it can affect parts of the brain that control swallowing, eye movements. It can also affect the part of the brain that controls your breathing when you sleep. So Chiari-2s can be a little bit more severe. Now, most people with Chiari-1s and Chiari-2s are born with them. These are congenital. So you're born with these conditions. Chiari-2s generally, like I said, are when you have hydrocephalus, you have a Chiari-2, and you have myelomeningocele. You're born with all these at the same time. There are situations where a Chiari can happen if you have loss of spinal fluid. So if something happens to your spine low down and the fluid leaks out, it can cause the Chiari malformation. Generally, we see this in sometimes Chiari-1. So we might see somebody who wasn't born with a Chiari, but they had some sort of spinal trauma, and it can cause the Chiari-1. So it's rare that these can be due to trauma. Most people are born with them, but it is possible.
Brad, can I also add that if you already have a Chiari-2 but have not been symptomatic in the same way, I do think that there are some potential traumatic things that can happen, which may make you symptomatic where previously you may not have been symptomatic.
That's a good point. So if the question is, maybe it's not the question isn't about the Chiari actually developing, but the symptoms of the Chiari developing. Maybe the Chiari was already there. The next bullet is about somebody getting tingling in their feet, somebody that probably didn't have sensation before, and now they do. And so I can't really answer this because I don't have a lot of details about specifically what's going on, but I'll give some answers as to how to think about sensation in the legs. So there's lots of different types of sensation. We have light touch sensation, which is like just gently touching the skin. That's a certain type of sensation. There's a sensation to pain or sharpness. So if I took a safety pin and touched it on your skin, there's the sensation of it being sharp. There's also pressure sensation. So if I pushed really hard on the skin, you might feel it farther deep down. And there's different pathways within the spine that carry those different types of sensation. So some people are missing different types of sensation depending on which part of their spinal cord was damaged. And then sometimes when they develop other problems with their nerves, the nerves can emit different sensations. So when the nerves are having problems, it can feel like burning, it can feel like tingling. So that might be a sensation that somebody develops over time, even though they didn't have other types of sensation before, because there's some problem like a neuropathy or a tethered cord problem. I also find that a lot of my patients have deep sensation, even though they don't have sensation closer to the surface of the skin. Like if I gently touch the skin, they'll say they can't feel it, but if I press deeply on the skin, they can feel it deeper down. So there are definitely some differences in how people with spina bifida can perceive sensation.
Brad, I agree with you absolutely. The one thing I would say is be aware of your body and whether or not those are changes that have been there or changes that are new. I do not have light touch or deep sensation in most of my feet, but if I sit in one position too long, I can get tingling. Again, those different pathways make a difference, but the question to my mind is, are those changes new for you versus are they something that you've always had and are pretty constant?
Yeah, that's a good point. If it's something new, it's something to consult a provider about. The next bullet is about neurologic changes to expect as you age. And I think I'm going to refer this one back to the presentation because this one's a big topic. There's lots of things that happen as you age. There's things to be aware of that are spina bifida issues, like tethered cord syndrome. And there's issues related to general aging, like developing osteoporosis or osteoarthritis. And these are some of the things that we talked about in that presentation. And the last bullet, this one asks about a gentleman who is now in his 40s who had a shunt put in when he was a child, but there was a thought that maybe he didn't have hydrocephalus at the time. And this one is really a difficult one to answer without knowing more about this person. But what I would say is that generally, a shunt is put in when the person is thought to have hydrocephalus or be at risk for hydrocephalus. That's why the shunt is put in the first place. Okay, we can go to the next slide. So this is a topic that I can talk about forever, orthopedics and mobility, because I see a lot of this in my practice. So I'll try to be as succinct as possible, but I have a lot to say about these bullets. The first question is about somebody who has a knee issue. They have a meniscus problem in the knee. The meniscus is like a little area that's between the knee joint that is like a cushion that helps protect the knee. And the knee buckles and gives out. And they have a question about whether knee buckling is common and what you do about it. And the answer is yes, I do see knee buckling quite a bit. And how you treat it really depends upon why it's happening. Some people have a knee joint that's not aligned directly. This is kind of natural based on the way that people's bodies are shaped. Some people with spina bifida, their feet tend to turn in, which causes a problem with how the knee is aligned, and it also affects how the hip is aligned. And so all of those joints kind of work together, but they can be out of alignment. And so over time, that person can develop arthritis in their knee because it's not aligned well and it can degenerate. People can also have knee buckling because their muscles are weak. So over time, if you're not someone who's physically active or something happens to you that causes weakness in the muscles, that can cause the knee to buckle as well because your muscles can't control the knee while you're moving. And so the treatments for this can be very, quite different depending on what's happening. If it's an alignment problem, we might treat that with orthotics or bracing that even sometimes goes all the way up to the knee. It might involve physical therapy to try to get the strength back in the muscles of the leg, if that's possible. Things to look out for that can be preventative. So staying active, keeping your muscles strong, participating in exercise can, help protect the knee. And another thing I'll mention is that a lot of people walk without their braces because they can. They'll say, I can get around without my braces. And while that may be true, the braces are not always just meant to support the joints while you're walking and help you walk. Sometimes the bracing is also prescribed as a way to keep the joints aligned so that they don't develop arthritis over time. And so sometimes keeping the joints well aligned and wearing your braces can help prevent that degeneration down the road. The next question is about leaning to the left and being told that it's just a normal effect of aging. The leaning, if the trunk kind of leans over time, it can be due to different things. Certainly scoliosis is one of those things. And scoliosis may need to be treated if it's severe enough. So it's something that you should really talk to your doctor about. We do find folks who are wheelchair users can lean for a variety of reasons. Sometimes it's scoliosis, but sometimes it can be due to the hips or the pelvis. And so, consulting your wheelchair provider, who may be a therapist or a rehab doctor, can also help to figure out what's going on if you're leaning and you use a wheelchair. And certainly, we always recommend participating in exercise to keep the muscles strong, the core muscles, so the muscles of the trunk. If you have the ability to contract those muscles, keeping those muscles strong can really help with posture. And then the last question is about aging adults who are losing the ability to walk or who have already lost their ability to walk. And I'm not sure whether what this question is asking as far as what can be done for them. I think the question is, if the question here is preserving mobility, I think it's really important to think about preserving mobility with technology. So whether that involves bracing or proper wheelchair use, that's something that certainly can be done. Treating osteoarthritis, and degenerative conditions is something that can be done. Also, screening and treatment for osteoporosis can be really important. So there's lots of different considerations here depending on what's going on with this particular case. The next question is about rotator cuff tears. And I really like this question. It's about how do you treat rotator cuff tears and whether a joint replacement is an actual treatment. And so there's lots of layers to this question. So let me first explain what the rotator cuff is. And I brought a model of the rotator cuff, which I hope will be helpful. So this is the long bone of your arm, and this is your shoulder joint, and these are the muscles in the shoulder. So you can see different muscles here and also in the back of the shoulder. So there's actually 4 different muscle tendons that attach to the arm bone, and they help move the arm bone around. So they attach like that. And we call that the rotator cuff. It actually has 4 separate muscles. And so any of those muscles can tear for different reasons. The one on the top, we call it the supraspinatus muscle. That's the muscle that most commonly tears. That's the one we see the most. And so people who have tears of that rotator cuff will complain that there's pain kind of going down the side of their arm. It might go down to the side of the shoulder muscle. They might have trouble picking their arm up, especially if they turn their arm in, it will hurt. And there can be strains of that muscle. There can be partial tears of that muscle where it's just partially not torn the whole way through, and there can be complete tears. And it can be very painful. It can cause a lot of inflammation, and it can really affect your function. And you don't want to progress to the point that you tear your rotator cuff. You want to try to prevent that, because the shoulder is really important for a lot of things that we do. It's important for reaching, it's important for transferring, and for people who use wheelchairs, that's how we propel our wheelchair. It's also how we use our arms to walk when we use braces and crutches. So if it's a mild situation where it's strained or it's just mildly torn, the treatments might be medications, it might be physical therapy. The shoulder joint can be injected with an anesthetic and a steroid. Those things can be helpful. If it's completely torn, it's generally something that has to be surgically repaired. Replacing the entire shoulder joint, though, that's replacing the whole ball and socket joint. That is a surgery that exists, but that's usually kind of an extreme surgery that's done only when the entire joint has degenerated. So that's when you have arthritis of the shoulder joint, and it's pretty severe. And there can be a lot of complications from shoulder replacements. Some people don't do so well after shoulder replacements. And it's really important to think about what the recovery would be like after a shoulder joint replacement. Kids, it can be difficult if you're somebody that needs your shoulders for transferring and using crutches or using a wheelchair. So that has to be planned out very carefully. The things that you can do to prevent rotator cuff problems, there's lots of things that should be considered. So keeping the shoulder muscle strong. So exercise, there's certain things that you can do with physical therapy or just with daily exercise that can keep your shoulder muscle strong and prevent them from tearing. Learning how to transfer properly. Believe it or not, there's actually good ways to transfer and bad ways to transfer. And by bad ways to transfer, I mean ways that you can transfer that can tear the rotator cuff. So it's good to be trained on how to transfer safely. Wheelchair, for those who use manual wheelchairs, it's really important that your wheelchair fit you correctly and be set up correctly, because an improperly sized wheelchair, especially a wheelchair that's too wide, or where the axle is put in the wrong place, when the axle is a little bit too far back, it can also cause problems with the rotator cuff. And finally, the rotator can be affected by weight. So if you are propelling a very heavy wheelchair, or you're putting a heavy backpack on your wheelchair, your shoulders are feeling all of that weight. And that's really not good for your rotator cuff. And that's why also the weight of yourself, your own body, is important. The heavier you are, the tougher it's going to be on your rotator cuff. The next question is about nutrition and exercise. So, good nutrition and exercise is something that everybody needs. It's not just for people who, do not have disabilities. People with disabilities also should exercise. Sometimes that has to be done in an adapted way, however. And what I always do in counseling people is tell them that, there's certain amounts of activity that are recommended. So there are actually physical activity guidelines, and we have physical guidelines about physical activity and exercise in the Spina Bifida healthcare guidelines that adopt national guidelines. So it talks about the different levels of exercise and how many minutes per week that everybody should get. But I think it's really important to think about also the type of exercise that you have. So there's resistance exercise, like lifting weights. There's stretching. There's cardiovascular exercise, which is where your heart rate goes up and you get sweaty. And those are all really important types of exercise, and all are important for your body. So you should really, think about the exercise that you like to do and incorporate, those different types, because they all have different beneficial effects. There's different types of people who can guide you on what specific kinds of exercise you should have. Physical therapists are great with this. Rehabilitation doctors like myself can also help answer these kinds of questions. We even have, lots of people that are experienced with adaptive sports and who are athletes and who have a lot of knowledge about how to adapt pretty much any sport that you're interested in playing. Can be done in an adaptive way depending on your mobility level. Okay, we'll move on to the next slide. So pain, this person is asking about back pain. This person happens to have a lipoma over the back, sacrum, kind of the lower part of the spine. And what I will say here is that back pain is a very complex issue. Treating back pain really depends upon why the back pain is happening. There's lots of different reasons why somebody can have back pain, and the treatments are all different based on where the pain is coming from. Just because you have spina bifida doesn't mean that you should suffer from back pain. Back pain in many cases can be treated, but you need to find the right provider who can figure out why you're having the back pain. People with different types of spina bifida that have lipomas or fatty tissue, lipomyelomeningocele, those folks can have a tethered cord. Tethered cords can happen in people without these conditions, but tethered cord can be a source of back pain, as can other spina bifida reasons. But what's also important to understand is that people with spina bifida get back pain for other reasons too, just like everybody else. They get spinal stenosis, they can have problems with their discs, they can have muscle strains. The treatments for those things are all different. And so the real question here, I think, is what type of provider should you see? So if it's spina bifida related, generally a neurosurgeon is the person that treats that. If it's not neurosurgical, then a rehabilitation doctor like myself can treat back pain. Neurologists sometimes can treat back pain. There are pain specialists and spine specialists of different specialties. And sometimes orthopedic surgeons treat back pain. So there's lots of different types of providers. The key here is just going to a provider first who can help diagnose it and then get you along the treatment pathway. So if you're not sure where to start, if you're not sure whether it's spina bifida related or not, I would say go to a neurosurgeon, go to a PM&R doctor, and we can help you from that point, figuring out what is the best treatment path. There's also a lot of information in the presentation from last month, as well as a separate seminar that we did on spina bifida occulta. So there's lots of things to understand about spina bifida occulta and how pain relates to it or does not relate to it. We developed a lot of resources for folks that have that condition. The next bullet is about a person who has spina bifida, but also another condition called osteogenesis imperfecta, which is a problem with the bones. And she uses a power wheelchair, and she has lots of pain issues, especially in her neck and arms. And the problem here again is, finding doctors who understand spina bifida. And so I think here again, this is more of a question about just finding a good provider who can diagnose the problem and get you along the right treatment pathway. So if in absence of a spina bifida clinic, if you don't have a clinic in your area where you have providers who are knowledgeable, a PM&R doctor or a physiatrist would be a good place to start. And if you're listening, you can also contact the National Resource Center and we can help you. And then the last bullet is about aging, back pain, and spina bifida. I think I touched upon this a little bit, but I'd also refer you back to all of the factors related to aging. It took us about 90 minutes to go through all of the conditions to think about with regard to aging and spina bifida. So please refer back to the presentation from last month. Next slide is about preventive care. The first one is about dealing with multiple complications at the same time. And I thought this was a really great question because it points out how many things can be going on at once, how things change as you age and might become more difficult to manage, compounded with the fact that some people with spina bifida have executive dysfunction, which really impacts our ability to manage and keep track of a lot of things all at the same time. So what's key here, I think, is a couple of things. One is having a provider who can help you sort and prioritize these things, because sometimes it's not possible to deal with all of them at once, and you need a good plan, and you need someone who can follow you over time and work on these things. So we called this self-management. We also, talk about goal setting. So setting some really specific goals that might require conversations and agreeing with your physician about what's important to you. So we call that shared decision-making, where you and your doctor sit down and talk about, what issues to tackle, and you decide together, what to address at what visit. And also, having a team around you. So that might involve caregivers or family members who help you with some of these things. It might involve a nurse. It might involve a case manager. It might involve a neuropsychologist who can help you cognitively with your executive function. So depending on what's going on, there's lots of different ways to build a team around you. And I would also say that, we find technology to be effective in helping you keep track of things, things that allow you to keep track of your medical problems, smartphone apps that help you keep track of your medications and get reminders to do your different programs and to take your medications. So there's lots of things that can help, but it's important to really sit down with your team and come up with a plan. Related questions to that. So one person is asking about joint wear and tear. I think we talked a little bit about that with respect to the knee. So I think we addressed that one. There can be wear and tear of the shoulder as well, which we also covered. The next bullet is about resisting challenges that come with aging. So again, I think this is really about understanding that things do change as you age, but it doesn't mean that it's not treatable. I do think that, it's important to have somebody who understands mobility issues on your team, because that can be really important as you age. So somebody who can help you preserve your mobility as much as possible. So that might include physical therapy. It might include treatments for knee problems. It might include braces or changes to your wheelchair technology. But having somebody like that on your team, like a PM&R doctor or a wheelchair specialist or an orthotist, can be really helpful. Another question is about what aspects of spina bifida impact the aging process as you get older. And again, that was a whole entire lecture. There's lots of things that are related here. So I will refer you back to our presentation last month.
Brad, can I make one comment here?
Mm-hmm.
Since I have advanced to my 60s from my, in my advanced age, I think it's important to think about changes that are occurring really gradually versus changes that are happening more rapidly. So by really gradually, I'm meaning over years. It took a long time for me to move from walking independently to using crutches to support, because my muscles were getting weaker, my weight was getting heavier. So I think, again, changes that are happening more rapidly should be something that you really talk about with your physician, or physicians and your team. I have found that in my age, obviously the muscles that I don't have working don't work. The muscles that I do have working, for everybody, muscle strength, etc., changes with age. But I think those impacts alter what we're able to do with spina bifida. So I was independently ambulatory for much of my life. I started using crutches for long distances, or traveling, probably 15 years ago. Didn't use them other than that. Moved to crutches a little bit more full-time and moved to a scooter more full-time over the past 3, 4, 5 years. And I cannot point to any one single thing that was sudden. It was kind of so gradual that I had to make changes going on and I didn't think about it. But there are also rehab therapists, physical therapists, sports and fitness experts who are now specializing in aging and elderly populations as well. And I think trying to seek some of those people out in terms of what can you do to maintain muscle strength, aerobic activity, all of the things that you talked about is really important.
Thanks. And the one last bullet in this section is about concerns for someone who has used a wheelchair their whole life. And I think it's important to realize that folks who use wheelchairs early on are more likely to have myelomeningocele, which is a more severe type of spina bifida. They may be more likely to have a higher level of lesion on their back, which means that they might have more weakness or sensory loss. And these folks might also be more likely to have hydrocephalus. So having all of those things can make you more likely to have other complications, like, for example, the risk for skin breakdown. So that could be something moving forward, that someone as an adult who is aging, may have more skin issues than somebody who is a little bit more mobile. But this goes for a lot of other body areas too. So these folks tend to have more bowel bladder problems. They might have more orthopedic issues. They might have more neurosurgical complications. But I think what's kind of really important here is the theme that you've been hearing is that as you see changes, seek treatment, talk to your provider about it, because just because you're noticing challenges or changes, it doesn't mean that they're not treatable. What a knowledgeable provider needs to do is tease out what's related to spina bifida and what's not related to spina bifida. And all of these different changes all have different treatments. So it's really important to diagnose the problem so that it can be treated the right way. And there's lots of things to do with prevention. And I think we covered a lot of those things tonight and also in the presentation last month. The next question is about hypertension or high blood pressure. So this is something that we see commonly in adults with spina bifida. We don't have a lot of research to understand all the mechanisms for why this happens, but I can say there's probably lots of factors here. We published a study actually on our patient population that did find that a lot of our adults with spina bifida have high blood pressure. We talked about that in the presentation. We also listed some things that can be related to having hypertension. So those can be things like a person's weight, if you're overweight, if you are less mobile, if you smoke. Those can be some examples of some conditions that are also related that can put you at higher risk. Also, hypertension can be familial, so you can be more predisposed to having high blood pressure if it runs in your family. The next bullet is about cancer screenings. So we won't be able to go through all of the recommendations for all the types of screening that you should get. A primary care physician should be able to describe to you what screenings you need based on your age and whether you're male or female, etc. However, a couple of things that I do want to point out that are unique for spina bifida compared to the general population as it relates to cancer screening are, number one, when you're folks who need colonoscopies. Colonoscopies can be difficult to carry out when you have difficulty controlling your bowel. So sometimes the typical bowel preps that we use for colonoscopies in the general population don't really work so well in people with spina bifida. So it's really important to plan with your physician, what is that bowel program going to look like? How will I manage this at home? That has to be a conversation that you have ahead of time so that you don't run into a problem where the bowel prep doesn't work and then the colonoscopy is not effective. With regard to mammograms, what's really important to recognize is that women with disabilities in general tend not to be sent for screenings, even though they're indicated. So that counts for gynecologic screenings and all those things like mammograms. But also I want to point out the accessibility issues that might come along with getting those screenings. Some mammogram facilities aren't exactly accessible for wheelchair users. Some gynecologists' office aren't physically accessible. And I know The folks here in this meeting are probably, really aware of all those things. But when you're talking about what screenings are necessary with your provider, I think it's important to think about having a conversation about what providers to see, where can you go, what's going to be accessible to me. And another point here is with the bladder. I want to point out that people who have had bladder surgeries where their bladder has been augmented or reconstructed should be seeing a urologist, because there are recommendations that those folks might need cystoscopies or scopes of the bladder every once in a while. So just like we get scopes for our colon, some people also need them for the bladder. And the last question is about showering safely. So I think this is a good question. Some things here to think about. The accessibility of your bathroom. So some bathrooms are accessible, some are not. So talking to a provider about having the right equipment. Usually this is really important. This is kind of the key to showering safely, is do you have the right type of bath bench? Do you need a shower chair? Those are like what we call basic durable medical equipment products that are kind of like off the shelf. But there's even more custom or complex technology that we can use for showering that are more custom. They look more like a wheelchair. They even have tilt functions, and they can be used for toileting and also for showering. That might be something that some people may need. So rehabilitation physicians are familiar with how to order these. But occupational therapists can also be very helpful here. They can help you plan out what type of equipment you might need, what might fit in your home, and also transferring. So when we think about how do we transfer, how do we get into the shower, out of the shower, how do we get dressed, all of these things can be very complex for some people. And so occupational therapists can really train you how to do that in the best way. All right, next slide. So Spina Bifida Occulta, again, I think there's a lot of resources on this. We have an entire webinar series that has 2 parts that talks about Spina Bifida Occulta and all the complexities that come along with it. There's different considerations in terms of whether it's the benign form, which is very common, and also a more complex form that is less common, but involves some abnormalities of the nervous system. So I think the questions here are about, really come down to finding the right types of provider, and those webinars go over how exactly to do that. So the decision-making process, they give you a process for looking at, have you had an X-ray? Have you had an MRI? Based on the kinds of findings on the MRI and the symptoms that you're having, here's the right type of provider that you should see. And I went over that also in the presentation from last month. So I hope those resources are helpful. The decision tree for how to make decisions about who to see is a handout, and we can make that available to everybody. So self-management and living independently. The first question here is about comparing insurance plans and thinking about assisted living facilities. So I'm not an expert on insurance, but one thing I want to point out to folks that I find to be really important to my patients with regard to insurance is asking about coverage for durable medical equipment. So if you're somebody who uses a wheelchair or needs equipment, or you're someone who takes certain types of medications, always get clear information about what's covered and what's not covered when you're comparing different types of insurance. I think that's really important because some of these things can be really expensive, and a plan that covers some of these things might be helpful compared to a plan that doesn't cover portions of these things. think about what your copays might be also, for example. And I think in terms of assisted living facilities, one big question to ask is, what do the caregivers actually help with in an assisted living facility? Sometimes people require help with their bowel or bladder program. And sometimes some facilities don't have caregivers that are trained or who are able to provide that care. And so that's really important to think about. You may also want to think about facilities that offer a wide range of different living settings. So there's something called independent living, which is apartments where you live on your own. You can have your own caregiver come into those settings. There's assisted living, which where the facility provides the caregivers for you at different levels. And then there's also skilled nursing, which is where you have full-time nursing care. And some facilities have a combination of all three, which can be attractive to some people whose condition might change, and they might need to switch around and live in different parts of the facility depending on what's going on with them medically. That prevents you from having to transfer back and forth between different facilities. The next question is about just living with chronic pain and becoming older and being able to care for yourself. And I think what's important here is coming up with a long-term care plan. So it's something that I think a lot of people wait too long to do. Some adults rely on others to care for them, and then they don't have a plan for what will happen when their caregivers become ill or their caregivers become too old or pass away. And so those plans really should be made in advance so that you don't run into a situation where you don't have someone to help you with the things that you need. And that also goes for medical decision making and planning financially for yourself. And SBA has some resources about how to do those things. I also think that there's a lot of adults with spina bifida who are caregivers also. And you may take care of your children, but you may also take care of your elderly parents. And so it's important to think about, as you get older, are you able to do some of the caregiving that you need to do, or do you need help with that? And I think the last bullet talks about sometimes some people are resistant to taking care of themselves, and how do we deal with that? And again, I think, engaging your provider team, having the right support around you, coming up with a plan and goals, and deciding, sometimes you can't begin to take care of all aspects of your health right away. It has to be done gradually, and there's things you have to learn to transition to your own self-care and gradually learn to become more independent. And that's not something that we can do by ourselves. It's something that the clinic team oftentimes has to help with.
Brad, can I make 2 comments on the previous slide? So as someone who is 67, who has now had to go through Medicare planning, etc., I will just tell people that if you're dealing with trying to do this, the government does not make it easy to compare all of these things. The things that I have learned are that Medicare Advantage plans may be really good, but they often are based on a specific provider group. So for example, my hospital system that I use has an Advantage Care plan, but you have to use providers that are in that plan and part of that provider group. You can not do a Medicare Advantage plan, but then you have to do Medicare Part D, which involves drug coverage. And then you have to do what is called a supplemental plan if you choose to not do a Medicare Advantage plan. So there are some websites at the federal government level that talk to you about what these different plans are and what they do and what they don't do. But I will tell you that it's extraordinarily confusing, and it took me a lot of work to figure this out as I retired. So, you know, I don't have an easy answer for you for that, but there are some websites that can help you. And there are some people who specialize in Medicare planning and guidance that you may be able to utilize in your local area, depending on what your Medicare coverage options are. The thing I would say about the third bullet is if she's already 41 and has been good with healthcare, but is becoming more resistant. The things I would also think about, in addition to what Brad talked about, are what are other factors that may be related? So what is her living situation? What is her job situation? Is she depressed? Because when we're depressed, we are much less likely to do things that relate to improving our healthcare. And so I would think about not just the factors that Brad talked about, but think about what her current neurocognitive status is, issues of mental health, and other kinds of things that may be related to this. So I would say at 41, most of the people that I've met are fairly comfortable at doing their own self-care and have been doing it readily. And so if things are changing, what are features other than her medical condition, mental health, living situation, job situation, friendships, whatever else you can think about that may be contributing to this?
Those are great points. And also in terms of comparing insurance options, some, social workers are generally trained to help patients with that. Not all clinics have social workers actually right in their clinics, but some clinics have access to social workers. So that's something that you could also ask about when you're in clinic, to see if there's someone who's available by phone, or that can also answer some questions in more of an objective way, who isn't biased towards one plan or the other. All right, I think we can go to the next slide. Question on sexual health. This was an interesting question about procedures that look at improving sensation in the genital region. And first, I'd like to point out that, generally in a lot of cases, of course, sensory loss is related to spina bifida itself, but sensory loss in the genital region can also be due to things other than spina bifida. So some examples would be like if there's a nerve compression, there's a particular set of nerves that innervate this area. And if those nerves have problems for some reason, that can, like if there's a nerve compression somewhere, that can cause problems in the genital region. And also medical conditions like diabetes can reduce sensation in the region. So sometimes the treatment, again, depends on the underlying reason why this is happening. If it's sensation that has been missing for your whole life, that may be a different situation than sensation that is new or changing. If it's certainly new or changing, that's something that you want to get checked out. There are surgical procedures reported in research that talk about moving nerves, so nerve transpositions, where you can take a nerve from one area and move it to another area. And there is a lot of more research in this area where there have been some good outcomes with people developing some areas of sensation. It doesn't fix the problem completely, and it's still somewhat experimental. But some of these, I have seen a couple of articles published that have actually been done in spina bifida and not just spinal cord injury, primarily in men, though. So that is something to consider, but I think it's really important in this case to talk to a urologist about, what is the cause of the sensory loss. If it's something new, what can be done to treat it, if it's new or even if it's chronic. And there are some urologists who are specially trained in certain subspecialty areas. So I really like to refer to neurourologists who are more understanding about how the nervous system controls the urologic system. And there's even neurourologists who are even trained even more. So there are some people that specialize just in sexual health. You usually find those at bigger academic centers, but they do exist. And there are also urogynecologists. So, for women, sometimes that can be a really helpful specialty that combines urology and gynecology together. And they generally have a very good understanding of the nervous system. All right, next slide. So skin. So I think we did talk a lot about preventing pressure injuries, or some people might say pressure sores or pressure ulcers or decubitus ulcers. We covered that a lot in last month's presentation. So just briefly, some things to think about with regard to preventing skin injury. So there's pressure, there's friction, which is not direct pressure, but sliding across the skin. There's moisture. There's also nutritional aspects there, and there can be aspects of temperature. And all of these things kind of work together to potentially cause skin breakdown. So skin breakdown can be very multifactorial, if you will. And so the presentation talked about each of those different domains and what you can do to help prevent pressure, help prevent friction, help prevent moisture, et cetera. So I'd encourage you to kind of take a look at that because it's a lot to cover in this presentation, but we did cover each of those before. In terms of aging, I think, what you need to keep in mind is that just all of these things are accelerated, perhaps, so that some people become less mobile, and therefore they may be at more risk for skin breakdown. And as far as this first question about the skin feeling thin and tissue-like, sometimes that happens with aging, but sometimes it can also be an effect of medications. So that's something to talk to your providers about and ask whether the medications that you're on could be causing some of the changes in skin. Sometimes we see this with steroids. Sometimes we see it with blood thinners that can make the tissue bleed or bruise easily. So those are some things to consider. Questions always come up about, the balance between the right amount of protein and not eating too much protein, because it can be difficult for your kidneys, especially if you have kidney problems. So what I would suggest here, I can't make recommendations to this particular person because I don't know what your individual situation is, but I would suggest if you do have kidney problems, talk with your kidney doctor. Those are nephrologists, about what level of protein would be appropriate for your diet. They will generally have very specific recommendations about what your kidneys can handle. And dietitians are also very skilled in this area. They should be able to help you sort of understand how much protein you should be getting, but also what that means. So how to plan your meals and how much protein is in the different foods that you eat. The third bullet there, I think we covered. There are lots of reasons for pressure ulcers, and we talked about how to prevent them. And then the final bullet here deals with somebody who gets infections in their toenails quite a bit, and it became so severe that it required an amputation because the infection got down into the bone. And certainly, sorry to hear that. This is definitely something that we certainly want to try to prevent. Toenail fungus can be pretty common in people with spina bifida because parts of the feet don't get great blood supply. And then it can also be an issue with moisture. So sometimes when the feet are wet and that moisture gets trapped against the skin, it can be an area where fungus can grow very easily. So if you're somebody that tends to get fungal infections on the skin or on the toenails, a good type of provider to see is a podiatrist. They can really help you keep your toenails trimmed, your skin clean, and they can, if it's something that needs to be done as a procedure, they can do it very in a very sterile way in their clinic so that you're not as prone to an infection from damage to the skin. And I would also say keep the skin as dry as possible. You don't want to have a lot of moisture against the skin. So, for example, if you're wet getting out of the shower and you dress right away without drying your skin off, that can cause a problem. I usually recommend wearing a type of natural fiber in your socks and clothing because it will help the moisture can evaporate more easily. So cotton, for example, is generally a lot better than synthetic materials because the moisture can evaporate through. But also you don't want the skin to become super, super dry where it starts cracking open because then that can also cause an infection as well. So if you're someone who gets more of a dry skin, keep your skin moisturized. You want to keep it in the middle, not too wet, not too dry. All right, next slide. This question is about stem cell treatment.
So I looked into this issue a little bit as I saw that this question came up. At present, stem cell treatment in spina bifida is experimental. There are a number of centers internationally that will claim that they have had good success with stem cell treatments, but I caution you that those centers are not doing actual clinical research and subjecting their findings to peer review and to critique in the way that we consider to be appropriate for new treatments. I do think that stem cell treatments afford an important potential for us. There are 2 studies that I could find recently that have addressed stem cell treatment in an appropriate way. The first is that Dr. Diana Farmer at UCSF, University of California, San Francisco, has a study ongoing looking at implanting stem cells at the time of fetal surgery to see if that improves outcomes. SBA wrote a letter of support for that research because we believe in the possibility of stem cell treatments, but we also believe in the importance of research happening in a scientifically appropriate way. I have not seen any data to date on those outcomes, but that is going on. In addition, I saw a study that was done in Vietnam, published in 2023, looking at taking a person's own stem cells, and that is critical. Most successful stem cell work in something like spinal cord injury or cerebral palsy or other disorders that involve the spinal cord are using the individual's own stem cells. That can be umbilical cord stem cells. In the study in Vietnam, they actually took a sample of bone from the hip bone and grew stem cells from that. That is what we call a phase 1 study, meaning that they trialed it on a very few individuals. My recollection is that it was 11 people, and saw some potential promising benefits. But as they rightly pointed out in the various journals regarding stem cell interventions, they feel that while this may be of benefit, 11 patients is not enough to say that this is a success, nor is it enough to say what complications may occur over time. So we do have a statement with regard to novel therapies on the Spina Bifida Association website. But that is all that I can find specifically for what I would call reputable research with spina bifida at the present time.
And this last question deals with vision and eye care. This is a particular person who has a shunt, but also has a tumor. Typically, these kinds of tumors that affect this part of the vision, they can be pituitary tumors. Question here, I think, is really getting at what can be done or what should be thought about. And I would say the right type of provider here is a neuro-ophthalmologist. That's something that some people don't know exists. But just like we all should be getting eye exams once a year, there are ophthalmologists that are specially trained to understand how vision is affected by the brain and the nervous system. So this particular type of problem could be helped by somebody in that specialty. Again, it's neuro-ophthalmology. And I think we reached the end of the questions, so I will turn it back over to Judy to see how we want to handle the rest of the questions that are appearing in the Q&A section.
Well, we have secured the questions, and we will provide a written document. I'm not going to say how quickly because it'll take a minute. These are valuable questions. We appreciate them. We mostly appreciate y'all staying with us and Tim and Brad for this invaluable hour and almost 2 hours of answering questions that are really important to adults living with spina bifida.